Good morning, everyone. Um, this is our second last topic for rheumatology, and in this one, we are going to discuss seronegative spondyloarthropathies. So, first of all, what is seronegative spondyloarthropathies? Is basically uh, seronegative, in which their serum status is don't have rheumatoid factor. So simply, these conditions are spondyloarthropathies, or they are arthropathies, but their status is seronegative. They don't have rheumatoid factor in the blood. So we call them as seronegative spondyloarthropathies. Now to give you an overview about these conditions, uh, spondyloarthropathies are basically, we call all the conditions like rheumatoid arthritis is a spondyloarthropathy, SLE or even osteoarthritis is a spondyloarthropathy, but now rheumatoid arthritis has rheumatoid factor, so that is seropositive. So there are few conditions which are seronegative. So they share, like these conditions, they share some of the things in common. One thing which is common, like they don't have rheumatoid factor, and the other things which are common is like most of these conditions, not all, they affect mostly the axial skeleton. Now, few of the things which are very common in these conditions are this one, that they have relation to HLA-B27, and they call enthesitis. So enthesitis means what, like inflammation of the enthesis, or you can say inflammation at the sites where the tendons or ligaments are inserted into the bones. Now, what is there? We are going to discuss basically four different conditions. One is called as ankylosing spondylitis, one is called as psoriatic arthritis, one is called as reactive arthritis, and one is called as enteropathic arthritis. Now, one of the things which is interesting in this one, SLE and rheumatoid arthritis, which are seropositive, they are more common in females. Now, remember, seronegative are more common in males. So see, ankylosing spondylitis 3 times more common, psoriatic equal, reactive arthritis 8 times more common, but enteropathic equal. But conditions like rheumatoid arthritis and SLE, they are clearly more common in females. Okay. All of these, they affect young people. All of these, they give arthritis, but some of them, they give more peripheral arthritis, or you can say peripheral arthritis means what? Involvement of the bones of the hands and the feet. So, psoriatic, reactive, and this one do give. Ankylosing spondylitis seldom give. Distribution, ankylosing spondylitis, it affect the axial joints. So basically, it will affect the vertebral column mostly, or the sacroiliac joints. Psoriatic, any, reactive, and enteropathic basically affect more of the lower limbs. Now, one of the feature of this condition is sacroiliitis. Like the place where the sacrum is joined with ilium. So they all give, but ankylosing spondylitis, you can see 100% of the times you will find inflammation of this joint. Dactylitis is common in psoriatic arthritis. Enthesitis, the inflammation of the areas where the tendons are inserted. Almost all of them, they give commonly this kind of feature. Enteropathic give less common. Now, skin lesions in ankylosing, it is rare. In psoriatic, 100%, because see, it is psoriatic arthritis, so it comes with psoriasis. Okay, so 100% of the times. And reactive arthritis, it gives occasional keratoderma biloneragica, and this one can give multiple things like erythema nodosum or pyoderma. Okay, eye involvement. Ankylosing spondylitis, it is common. Rest are not so common. Urethritis now. Urethritis is inflammation of the urethra, so they do give, but not so common. And as I told you, all of them, they are associated with HLA-B27. So see, 90 to 95%, 40%, 80%, and 30%. So this is like the overview of these conditions. Now, I would like to start with ankylosing spondylitis. Okay, one thing which is clear about this condition is what? That it involves 100% the sacroiliac joints and the axial joint. So basically what happens is, it's a chronic inflammatory arthritis. It's a chronic inflammatory arthritis involving the sacroiliac joints. 100% of the times this is the one, and vertebra. So never forget the sacroiliac joint involvement. Okay. Now, one of the thing is, enthesitis. This is a very important feature in this one. Okay. Now, rest I show you that it can give uveitis. It is associated with HLA-B27. Okay, and so all these things are like I already showed you, right? So what happens basically in this one, there is inflammation of the joints, okay, of basically the vertebral column and the sacroiliac joint. Due to that inflammation, there is erosion, and due to that erosion, they will lead to ossification and osteoproliferation. Osteoproliferation means what? The bone cells will proliferate over there. So what will happen, like due to this long-standing, you can say, due to this long-standing inflammation, the end result is simply fusion. The joints get fused together. Okay. So this is the most important thing in this one, like the joints are fused together. So as I told you, it is more common in males than females, and most of the patients, they are HLA-B27 positive. Now, you have to remember the same thing which we were discussing about the inflammatory as well as the mechanical causes or the other causes, you can say. Um, Now, what happens is, it's an inflammatory condition. So, of course, like uh, there will be morning stiffness. So, of course, like it's inflammatory, so they're present with morning stiffness. So, they will be having more stiffness in the morning, or you can say more than 1 hour of morning stiffness will be there, right? And with exercise, same like rheumatoid arthritis and SLE, like same story is there because it is inflammatory cause. So the pain improves with activity or exercise simply, right? And whenever the person will go to rest will make the pain worse. Okay. Now, guys, you have to remember these things, because when you will, okay, back pain, for example, why I'm stressing on this thing, because uh, back pain is a very important presentation in the clinic. So you have to differentiate either it's a mechanical type of pain or either it's an inflammatory type of pain. So, for example, if it's a mechanical type of pain, so rest should improve the pain and exercise should make it worse. And the morning stiffness should not be that much longer. Okay, so this is how these patients present. Now, because it's the pain is in the axial uh, region, or you can say the vertebra and the sacroiliac joint, so they present with back pain or back stiffness, and in the night it disturbs them a lot. Some of them they complain of buttock pain, and they have painful sacroiliac joint. Okay, so we do a test called as Faber test, Faber, Faber test. So Faber test is basically positive in these patients. What is Faber? F is for flexion, AB is for abduction, uh, and this E is for and ER is equal to is basically external rotation. So what they do, like, okay, you can see a video of this one, how they perform a Weber test. By basically what they do, they flex, then abduct, and then externally rotate the leg. By the way, I can show you over here to make the thing clear. Faber test. So you can see like this one. See, the person is lying on the bed, and what they're doing is basically they are flexing, first of all flexion, then abduction, they are moving the leg a little over here, and then see they are externally rotated. So externally rotated, like when they will move it inside. Okay, so, or you can see over here, maybe we can find something like this. So see, yes, this is the Faber test they are doing, this one, right? So it is basically flexion, flexion, abduction, see the leg is far, and then they are externally rotate. Okay, so this is called as Faber test. Again, this one is the Faber test. So Faber test is positive in these patients. Okay, so we perform this test. Now, because their spine, due to long-standing inflammation, get fused together, so they have uh, decreased range of motion in the spine. So what happened? Basically, they have spinal restriction. We call it as bamboo spine. Looks like, that they have a bamboo in their back, like instead of vertebral column, they have a bamboo. Why? Because they have decreased movement in the vertebral column. So we do some tests called as Schober test. I will show you in a while. So this thing is the thing, like, they'll be having spinal restriction. Okay, like they cannot move their back like you can move. Like what are the movements in our vertebral column we can do? We can do forward flexion, backward flexion, lateral flexion, right? And even rotation. So that thing. Now, due to this, they have multiple postural changes. What postural changes they have? They have decreased lumbar lordosis. Now, if you know what is lordosis, the thing will be easy for you, but I will show you in a while what it means. They have increased thoracic kyphosis, okay, and they have increased cervical flexion. Okay, so what happens due to that? Like their wall to occiput distance become increased. So I will show you what I mean to say is like this thing. See, basically we have our lumbar area is like, see, there is a lordosis over here. So what happened in this patient, you can see like it's not like this, it's quite straight. So decreased lumbar lordosis and increased thoracic kyphosis. See, and due to this kyphosis, they have a hunchback. So that's why the occiput to wall distance is increased. So basically it is more than 5 centimeter. If you will ask this guy to touch his occiput, back of the head to the wall, he cannot, right? So this is how their structure looks like, right? So this is what is like lordosis, this is kyphosis, right? So normally we have cervical, so see, like he have increased cervical flexion. Normally we don't have like this thing, our neck is like this, right? So normally we have cervical lordosis, thoracic kyphosis, then again lumbar lordosis, and then again sacral kyphosis. This is the normal, okay? Or you can see in this photograph like cervical lordosis is not shown over here, then thoracic kyphosis, and then lumbar lordosis, and then like sacral kyphosis, right? So what happened in these patients is they have increased occiput to wall distance, they have more cervical flexion, they have increased thoracic kyphosis, they have decreased lumbar lordosis. Okay, so these are the changes they all have. So these are the clinical features why now there is fusion is going on. Okay, like their vertebral columns are fused. Okay, now as you can see, like they have multiple other type of abnormalities as well. For example, they have asymmetrical, they may have asymmetrical large joint joint arthritis. Okay, so it can involve their multiple joints. Okay, they have anthesitis, right? As I told you. Now, not all, but they may show some extra-articular features like uveitis, right? They may present with uveitis. Not so common, but it can occur. Now, whenever they have ankylosing spondylitis, they have increased chances of developing inflammatory bowel disease. Okay, so like Crohn's disease or ulcerative colitis, and they have some cardiac manifestations as well, like aortitis, aorta inflammation, aortic regurgitation. Okay, they may develop pericarditis. Okay, and conduction abnormalities as well. Now, ankylosing spondylitis can give apical fibrosis of the lungs, as well as now because of like in very severe cases they may develop quadra equina syndrome, like because of their spinal cord get affect as well. So now this thing they can develop. So like these are some of the features which are not there. So how we investigate them, guys? First of all, we go for X-ray. So when we do X-ray, one of a very very classical sign we can see is like this is the sacrum, right, and this is the ilium. So this is the sacroiliac joint, you can say. So there is pseudo widening because there is erosion going on over here in the sacroiliac joint. So this is pseudo widening of the sacroiliac joint. Okay, so this is one of the findings you can see. And then when we take the X-ray of the spine, so you can see like their vertebral bodies look like a square, or you can see over here. So we call it a squaring of edges. So normally the vertebral column, like these edges are protruded outside. So in this one, when we do the X-ray of spine, there is squaring of edges. Okay, so we also call it a shiny corner sign. Okay, so this thing is one of the thing, and like that's why see it's look like a bamboo. Okay, like the spine looks like a bamboo, so that's why it is called as a bamboo spine. So this is one of the sign which we can see. You can go for MRI, so MRI can tell you in detail what are the changes in the bones, in the cartilages can be seen, right? So now, guys, one more test to remember, like in this one is called as Schober test. What did we do? Like, and now because their spine is fused, so normally see when you bend like this, so like you can do a lot of flexion simply. So what we do, like we put 3 marks by the way. Okay, basically one marks 10 centimeter above the you can say dimples of Venus. You can say, like, when you will see the back of the patient, you will find dimples on both sides. They are called as dimples of Venus. So one line we put, like one mark we put around 10 centimeter above, and one mark 5 centimeter below. Okay, so there are two or three ways to do this test. So uh, then we ask the patient and we measure, okay, the distance. So the patient will bend completely like this forward, right? So what you can say, we measure the distance, okay, like if there is, like, they are like these lines are getting apart or not, right? So we measure this thing. So someone who have like restricted movement, of course, like they cannot be what you can say, this measurement will not be too much increased simply. Okay, so like this is called a Schober test. Now this is like this test is not so important. Like this is simply to check for restricted movement, guys. So now one way to remember these things is, like the extra-articular manifestation of AS is ankylosing spondylitis. Remember, there is 6 A's. 1 A is atlantoaxial subluxation. They do not remain stable. 1A is anterior uveitis. 1A is apical fibrosis of the lungs. 1A is aortic regurgitation. Okay, many of these patients, they can develop, not many of these, but rather many of the chronic disease patients, they can develop amyloidosis. So 1A is this thing. And, inflammatory bowel conditions are basically autoimmune. So autoimmune inflammatory bowel diseases, mostly they develop ulcerative colitis. Okay, mostly they develop ulcerative colitis. So see, like these are the 6 A's. 1A is this one, 2nd A, 3rd A, 4th A, 5th A, and 6th A. So if you write this one as anterior uveitis and this one as autoimmune inflammatory bowel disease. So this is how they present. And now how we treat them, treatment of this condition, guys. They are young patients, okay, and what's going on, of course, there is inflammation going on, and chronically they can get fused together, and there will be decreased movement in the spine. So all these things are occurring. So first of all, you can say conservative management or non-pharmacological management. We ask them to do exercise. Swimming is the best exercise for them. Okay, we ask them to do deep breathing exercises so that uh, like their chest should be in continuous movement. Deep breathing like will make their chest expand more, because uh, due to this, there could be chest expansion restriction as well later on. Okay, then we ask them for smoking cessation. Okay, that is a very important thing to do in these patients. And then we go for pharmacological management. So guys, it's an inflammatory condition, so remember NSAIDs should be given. NSAIDs are the first line of therapy. Okay, if they are developing any uveitis, give them steroid drops for eyes. Okay, of course, like to uh, decrease, you can say, the uh, systemic complications. So you can say for anterior uveitis. Okay, so steroid drops can be given. Now, if they develop peripheral arthritis, like the small joints of the hands are done, so how we treat rheumatoid arthritis, we can give them DMARDs. Okay, so DMARDs can be given. Nowadays, of course, like for like new agents are available, which I discuss in rheumatoid arthritis, anti-tumor necrosis factor are there. And chronically, simply because these patients, they get restriction of movement, and they get like multiple other problems, so we can go for surgical options. So surgical options like if there is too much deformity, so you can do vertebral osteotomy, like to make it better. So this is the condition, and this is a relapsing remitting type of condition. You can say there are relapses, there are remissions, okay, and like the prognosis is good if the female, if there it's a female, and if the age of onset is more than 40. So and by the way, many of these patients, their hip joint get involved very very commonly. So that's why many of these patients, they also like needed a hip replacement, a surgical option. So this is how this condition present. Rest of the conditions are not so important, but okay, just three lines about each one. Enteropathic arthritis now. Now enteropathic arthritis, you can see like intestines are there, right? So basically, this kind of arthritis, basically the people who have inflammatory bowel disease, like ulcerative colitis or Crohn disease, ulcerative colitis or Crohn disease, right? These are the inflammatory bowel disease. So what happens, like many of these patients, like who have this one, inflammatory bowel disease, they develop arthritis. Okay, and mostly like their large joints are involved, and it is an asymmetrical type of arthritis. So we call this thing as enteropathic arthritis. Okay, and this is the only thing. And simply, guys, this one, like these people are again HLA-B27 association we can found in these patients. Okay, and like both ulcerative colitis and Crohn disease, they have the equal, you can say, chances of developing this condition. And one thing is called as reactive arthritis. Now, reactive arthritis. Arthritis. So reactive arthritis, if I don't know, like I have any photograph for that to remember or not, but okay. Anyhow, reactive arthritis, you have to remember, like it's a triad. You can say there are three main things which occur in this one. I will tell you what are these three. So now these are the patients, who develop arthritis after some GIT or genitourinary infections. Okay, so like the onset of this condition is mostly there is some GIT or genitourinary infection, and after that, this kind of reactive arthritis, it started appearing. Okay, and most of the patients, who have this GIT or genitourinary infection, they found like it is due to Shigella, Salmonella, Campylobacter, or chlamydia infections. In most of the genitourinary infections. So simply the history goes like this way, like it appears like 1 to 4 weeks after the infection, which could be genitourinary or gastrointestinal. Salmonella, Shigella, Campylobacter, and this one, remember, chlamydia. And now, after this infection, they started developing this arthritis, and it can last up to from weeks to years. And when we further investigate them, we found them that, again, like if you will remember this one, reactive arthritis is more common and very, very, very common in males, 8:1. Okay, and they have a strong association with HLA-B27. You can see over here, right? So they do have a strong association with HLA-B27. So very common in males, very common association with HLA-B27. Now, the thing you have to remember, it's a triad of arthritis, okay, with conjunctivitis, with urethritis. So, of course, it's very common in males, but if it will be a female, so In females, cervicitis, inflammation of the cervix, okay. So conjunctivitis, or you can say uveitis, right? Anything can occur. So this is the triad, okay. Reactive arthritis is a triad of this thing. So basically they present with peripheral arthritis. Again, okay, most of the seronegative one are asymmetric arthritis. And many of them, they develop especially, your Achilles tendon, so Achilles tendonitis. Okay, so this is how they present. And they present with uveitis or conjunctivitis, and they develop urethritis. Now, there is one dermatological manifestation which I wanted to show you. It is called as keratoderma belonorhagicum. Okay. Now, why I wanted to show you, because sometimes, either they will give you this triad, or they will talk about like this one is associated with what in many of the MCQs. So that's why keratoderma. Okay, so basically this one appears like this way. This is the skin lesions on the palm and the soles. So see, the palms, either they are showing you the soles, or either they are showing you the palms. So what you can see over here, there is hyperkeratosis. See, the skin is too much proliferating. So there is hyperkeratosis of the palms and the soles. Okay, hyperkeratosis of the palms and the soles. So this is called as keratoderma belonorhagicum. Okay, one of the thing which I'm saying as urethritis, many of these patients also have balanitis. Okay, so we call it as balanitis circinata. So what is that basically? See, yes, this one. See, they have painless ulcers on the glans penis. They have the painless ulcers on the glans penis and also at the urethral meatus. This is diagnostic. Okay, whenever the patients they develop this thing, it is diagnostic for this condition. It is called as what? Balanitis. Okay, so this is maybe, yeah, no, but this one not so clear. So this is like keratoderma belonorhagicum and this one. Okay, like these two things can be present. This one is diagnostic. Okay, like this one and this one, they are diagnostic of this condition. Okay, rest like they may have oral ulcers. They can present with oral ulcers. They can present with diarrhea. Okay, so things like this. So about reactive arthritis, guys, this one is mostly a clinical diagnosis with some laboratory, you can say, testings. For example, you can check for HLA-B27 positive status, right? So when that status is positive, and you got this evidence, so of course we make the diagnosis of reactive arthritis. So the treatment is again same. We provide them with NSAIDs. Okay, we provide them with corticosteroids, sulfasalazine, methotrexate, anti-TNF, alpha therapy. All these things. So most of the patients, they like this one goes away with time. The last one which I wanted to discuss is psoriatic arthritis. Now, you had done psoriasis in dermatology, right? So remember that, psoriatic are like many of the patients, who have psoriasis, they can develop arthritis. We call it as psoriatic arthritis. Okay, so simply this is arthritis associated with psoriasis, and why it is caused, again we don't know exactly the mechanism, but they found many genetic, immunological, you can say, and environmental factors. But of course, like the exact thing we don't know, right? So psoriasis is very common, by the way, in this world. Psoriasis affect around 1% of the population. And out of them, 15% of the patients, they can develop this psoriatic arthropathy. So how, if you remember about psoriasis, how psoriasis appears, basically, it's a um, silvery scales on well demarcated uh, erythematous plaques. So now, one very important feature which I wanted to tell you is they have nail involvement. Okay, they have nail involvement in this one. So I want to show you the nails. So their nails look like this. So they have pitting. You can see like there are small pits. Okay, pits. You can see a lot of pits. Okay, so they have pits with multiple ridges, longitudinal and transverse both. So can you see the ridges clearly with transverse ridges? And their nails become discolored, and you can see like there is hyperkeratosis going on, right? And now their nails get separated from the nail bed. We call it as onycholysis. So we call this thing like as, so there is pitting, simply pitting is there. What other things, ridging is there, hyperkeratosis is there, and what is there, like discoloration is there, and one thing is on onycholysis. Okay, onycholysis. And you will find like oil drops in their nails. You can see over here. So see, like this one. So these are the nail changes. They're very important to remember. So remember, the nails are the part of skin, guys. So maybe you have done this thing in psoriasis. So see, like many of them, they have deformative arthropathy, like their joints become deformed. So simply, these are the dermatological features. Like they have the psoriatic rash. They have what you can say, nail involvement, right? So whenever like we check the patient of psoriasis, by the way, never forget to see the head, like to never forget to miss the hidden areas like gluteal folds, like uh, you can say umbilicus, hairlines, ears, all these things. Okay, we have to check. So musculoskeletal, like what joints they involve, guys? Remember, they cause mostly asymmetric, uh, oligo arthritis. Okay, most of the time, it is like this one. Now, one thing which is very important, I told you about rheumatoid arthritis. It involved the PIPs. So remember, this one involved the DIPs. Okay, this is very important to remember. It involved DIPs. Okay, so DIP with nail changes. Very easy. Like see, what joints are near the nails? It is DIP. So that's why you can remember. So it causes destructive arthropathy. Like simply, the joints become completely, you can say the shape is changed. One of the pattern, you can say, like there are 5 patterns we can see. One pattern is this one, second, third, fourth one is like many of them, they present with symmetric polyarthritis. You can say like same like rheumatoid arthritis. So this is the most common one, asymmetric oligoarthritis. And in males, mostly whenever it occurs, they can present with sacro iliitis or and spondylitis, right? So in males, like these are the things. So rest, guys, it can give extra-articular features, or like same like what we have done in um, ankylosing spondylitis. It can give uveitis. It can give conjunctivitis. It can give what you can say, aortic insufficiency. So like same like that, Again, apical lung fibrosis. It can give quadra equina syndrome, and like this, right? So it can give what you can say multiple type of presentation simply. So now how to treat this one? Of course, like treat psoriasis. Okay, this is the first thing, of course, like because this one comes with psoriasis. So of course, like you have done the psoriatic treatment, but we are discussing it from this joints point of view. So provide NSAIDs, okay, for arthropathies, or DMARDs, same like what we give in rheumatoid arthritis. Okay, so this thing. So this is how psoriatic arthritis they present, right? So remember, guys, psoriasis runs in families, okay, and uh, there is a criteria to diagnose psoriatic arthritis. No one will ask you, by the way. It is called as Casper criteria, but uh, you don't have to remember them. So, like, we have to go in the treatment the same way: treat psoriasis, NSAIDs, and DMARDs, which we give to the patient. So, that's all about spondyloarthropathies. You just have to remember the main features of these conditions, okay, and how they collectively are negative, spondyloarth, like spot negative one. So our next topic will be gout. That will be the last one. So I will see you in the next lecture. Thank you so much.